in someone with sepsis, they wanted to actually get return of the glycocalyx. Next is cytopathic injury and mitochondrial dysfunction. Now, remember we said you have both a pro-inflammatory and an anti-inflammatory process going on. Now, the pro-inflammatory phase, now the pro-inflammatory mediators and or other products of inflammation cause sepsis-induced mitochondrial dysfunction. For example, impaired electron transport chain. Now, this is the mitochondria, basically, and remember the Krebs cycle. We shall look at it again in more detail. And this is the electron transport chain. Now, importantly here, we note that TNF-alpha and nitric oxide cause dysfunction of the inner membranes. So remember this anatomy, we have an outer membrane, intermembrane, and inner membrane. And it is in the inner membrane, if you follow this line, it's in the inner membrane where the electron transport chain proteins are attached, the complex 1, 2, 3, 4, and then CoQ enzyme, and then cytochrome C. Now, TNF-alpha and nitric oxide cause dysfunction of the inner membrane and matrix of the matrix of the mitochondrial proteins. And this is followed by degeneration of the mitochondrial ultrastructure and therefore impairing electron transport chain. And that is very important for you to remember. And we shall see ahead other things that cause it is that amongst other things, this nitric oxide and the TNF, they do that. But once this outer mitochondrial membrane is damaged, it releases cytochrome C into the system. And cytochrome C is actually involved in apoptosis. But let's move forward. Okay, so now this is now the deep part of the Krebs cycle. So let's go through it. Now, this one, I hope you can see my cursor. Let me get annotated. Okay, I hope you can see the red point here. Now, this is glycolysis pathway, and this is the Krebs cycle, the tricyclic carboxylic acid cycle, and this is the mitochondria. Now, usually in normal life and health, you have glucose, glycogen feeds into it, then we have the phosphofructokinase, then you have your pyruvate, and then depending on the redox availability of NADH and NAD, you get either lactate or pyruvate. And then since you have enough oxygen and ATP, you go down and you form tricyclic acid cycle and you form more ATP. The whole idea is that one molecule of glucose from the glycolysis pathway gives you 2 ATP molecules. From that one molecule, if it comes down here, it moves down here, you end up forming 30 extra molecules of ATP. So one glucose molecule ends up forming 32 in someone who is very normal. Okay, now we have already said in sepsis there's tissue hypoperfusion. So what happens with tissue hypoperfusion will also cause reduction in ATP. Now, if you have a reduction in ATP, you have an imbalance here. You have very little ATP compared to ADP. Now, if you have very little ATP, it ends up activating phosphofructokinase. Now, here where you have adequate ATP, phosphofructokinase is inhibited. So on this other side, when you have hypoxemia and hypotension, when phosphofructokinase is activated, you end up, yes, going through the glycolysis pathway, forming pyruvate, but here we also have an increase in NADH compared to NAD, and therefore the net effect is taking the system to form lactate, again, lactic acid at the end of the day. And that is why, as expected in septic shock, even in the guidelines, amongst other things, they sometimes encourage you could measure lactate. And this is basically how you expect the lactate to come in septic shock. It's very important to remember, and I will explain how lactate can cause hypotension later. Now, because of this imbalance, you can see the mitochondria is not activated. The excess NADH compared to NAD inhibits mitochondria, and the less ATP inhibits the whole tricyclic carboxylic acid pathway. Now, that is the extreme end of sepsis. Now, in the normal early stages of sepsis, we have something different. Yes, we have this thing. So think about it. Someone has sepsis, is progressing to septic shock, not yet a septic shock. The body realizes the patient has reduced filling at the baroreceptors, and therefore, amongst other things, renin-angiotensin system and the noradrenaline pathway is activated, and we have adrenaline and etc. So in the hyperdynamic state of sepsis, so we have a hyperdynamic, we have a hypodynamic. So in the hyperdynamic phase of sepsis, the tricyclic acid cycle is also affected, but in different ways. So here we have epinephrine, which is produced to try and increase the blood pressure. Now, this epinephrine activates the beta-2 receptor. It goes and actually increases glycogen production. And if it increases glycogen production, it actually activates the glycolysis pathway. And here's the interesting part. Since you are not yet at the very extreme, as in the previous one that I showed you, you can end up forming lactate, yes, but then you can also go ahead and do some TCA cycle pathway will happen, but not as efficient as the other one. So in the hyperdynamic phase of sepsis, yes, you have both lactic acid production, but then still, since you have some amount of oxygen, you can still undergo tricyclic acid cycle pathway. And but the good thing is this: even if you are able to utilize the lactate, no matter how much you produce in a day, for example, exercise. After an exercise, people produce so much lactate, but you have the ability to use and dispose of it. Therefore, it's okay. But when you don't have it, that's when a problem comes in. Okay, so let's move to the next one. So then the next one is cell death pathway activation. So we have many pathways of death as a result of this metabolic dysfunction due to a dysregulated immune response. We have apoptosis, pyroptosis, autophagy, necroptosis, ferroptosis, pyroptosis. There are quite many, but we shall just deal with a few. So apoptosis. Now, during sepsis, pro-inflammatory cytokines may delay apoptosis in activated macrophages and neutrophils, thereby prolonging or augmenting the inflammatory response and contributing to the development of multiple organ failure. And that is very important to remember. Neutrophils in the body usually have a half-life, or they say up to, let's say, 1 to 2 hours, but in sepsis, their half-life increases to more than 6 hours. Amongst other things, there is due to the inflammatory milieu, it actually inhibits the pro-apoptotic molecules, okay? And therefore, they last longer. But the problem of lasting longer is that they are activated cells and they can cause more damage. Now, sepsis also induces extensive lymphocyte and dendritic cell apoptosis, which alters the immune response efficacy and results in decreased clearance of invading microorganisms. At this point, it's important to mention that the immune system has two parts, innate and adaptive. In the innate cells, we have the neutrophils, dendritic cells, macrophages. In the adaptive, we have the lymphocytes. Now, you need your lymphocytes to be activated to regulate the whole immune system and to actually give a better immune response. But sepsis, it's a bit imbalanced. You have an excess apoptosis of lymphocytes, and therefore you cannot regulate the immune response very well, and you cannot effectively clear the pathogens that are affecting you. So the other mechanism of cell death is pyroptosis. So just to make it simpler for you, pyroptosis is basically cell death due to excessive activation of inflammation. Okay, so let's see what it is here. So activation of node-like receptors. So node-like receptors are like the things which I mentioned in the beginning. Those are pathogen recognition receptors. So activation of node-like receptors can trigger highly inflammatory programmed cell death by caspase-mediated rapid rupture of the plasma membrane termed pyroptosis. Now, in both of them, there is caspase activation. To the interested reader, you could just notice some differences here. So let's start with the apoptosis side this year. You can see, again, a death ligand, for example, tumor necrosis factor alpha, interacts with the death receptor, and it leads to activation of caspase 8. Caspase 8 at the end of the day leads to this whole pathway leads to activation of caspase 3, and this one causes apoptosis. On the mitochondrial level, what I wanted to show you, remember we saw that there is a disruption due to tumor necrosis factor alpha and nitric oxide that is excessively produced. There is a disruption of the outer membrane, of the inner membrane of the mitochondria, and therefore you have production of cytochrome C. Now, the cytochrome C also goes and actually activates the caspase system. As you can see here, it activates the caspase system and you get apoptosis. Now, pyroptosis, as I've already told you, it's an inflammatory death of the cell. And basically here, you have a process that leads to activation of caspase 1, and this causes cell lysis. It creates a hole in the cell, and you end up, the cell ends up dying. The other process that is very important in sepsis, the other process of cell death is autophagy. Now, autophagy is basically the cell eating itself. For example, if a neutrophil goes and engulfs a bacteria and it endocytoses it forms a vacuole around it. Now, after killing that bacteria, what happens? It ends up forming other vacuoles, and it basically condenses itself and kills itself, and it dies like that. That is usually how the immune system is normally controlled and abated. But then once you inhibit the apoptotic pathway, they just continue living and causing many problems. Okay, so those were some general features. Now let's go to organ specific effects of sepsis. First one is septic shock. Okay, like our patient, I think the patient had septic shock. So this is just a repetition of what I've already told you. So you have the nidus of infection and abscess, pneumonia, whatever it is, which affects the organism, and then there is exotoxin production. Now, this exotoxin production interacts with cells such as monocyte macrophages, endothelial cells, and later they produce exogenous mediators such as cytokines, such as tumor necrosis factor, platelet activating factor, and others, and also cyclooxygenases, complement, kinin, coagulation, and all those things. So what the net effect they have on the vasculature, they cause vasodilatation, and there's also vasoconstriction. This in particular, I'll talk about it when I'm speaking about kidney injury. And then there's leukocyte aggregation. And then there's also organ dysfunction and myocardial depression and dilatation. Now, the myocardial depression happens in multiple ways. Number one, the myocardial depression can happen due to the effect of the toxins produced by the bacteria, or the effect of the excess inflammatory cytokines produced, but also because of the lactate, which we have already discussed. And it basically, what it does, it just makes the heart insensitive to other catecholamines, and therefore inotropy is reduced. Therefore, you end up with shock, which can cause multi-organ failure, and refractory hypotension, and both of these can lead to death. So that's the sequence of septic shock. Again, you will notice that there are very many mechanisms in sepsis to describe one organ failure. So perhaps I may not mention the mechanism you are aware of, but there are very many. It's not one mechanism, there are very many. So that's how septic shock happens. Okay, so the next one, let's look at disseminated intravascular coagulation. Again, we go back to the basics. We have sepsis, activation of the immune system, and we have activation of the monocytes. Now, monocytes are examples of innate immune cells. Now, when monocytes are activated, they produce tissue factor. Now, tissue factor is very important because it activates the extrinsic pathway of coagulation, okay? And then at the end of the day, it will activated tissue factor and activated factor 7 end up activating intrinsic pathway. So it's a whole process, and you have fibrin deposition. You basically form the whole clot and you form fibrin deposition. However, these pro-inflammatory cytokines that we have already mentioned, they also activate the endothelium. And once they activate the endothelium, they produce plasminogen activator 1. And this causes insufficient removal of the fibrin deposits. And then we also have impairment of anticoagulant mechanisms, especially we have a reduction of activated protein C. and thrombomodulin. They're reduced. And therefore, at the end of the day, you end up forming microvascular thrombi, and these ones become very many, and then they end up causing hypoperfusion at the cellular level because they can block the system. But also, on the other hand, is that you can end up causing so much of this that you end up consuming all your clotting factors, and that is called consumptive coagulopathy, and you progress into uncontrollable bleeding. Next, the pathophysiologic mechanism of ischemic acute tubular necrosis. So the mechanism I want to describe is the acute tubular necrosis of kidney injury in sepsis. So as I've mentioned, if you start with this diagram, as I've mentioned before, we have bacteria, you have endotoxemia, you have induction of nitric oxide synthase. It causes nitric oxide mediated arterial vasodilatation, and then the heart communicates with the brain, and the brain increases sympathetic tone, activates the renin-angiotensin system, and it also increases arginine vasopressin. Now, very important for you to note, I'll delve deep, a bit deeper into the vasopressin. Now, remember at the nephrons, we have the afferent and the efferent arterial. The whole idea is that at any one point, you want something that perhaps causes afferent arterial dilatation and efferent arterial constriction. That one creates a pressure difference, and there's glomerular filtration. So the problem with the production of excessive pro-inflammatory mediators, such as tumor necrosis factor alpha, nitric oxide synthase, and the epinephrines and everything, they unfortunately, amongst other things, they cause the afferent arterial to constrict instead of dilate, and it causes a problem. But vasopressin, on the other hand, only affects the efferent arterial, doesn't affect the afferent arterial. So at the end of the day, you have renal vasoconstriction with sodium and water retention. So that's at the global level. So now let's come here. I think I'll maximize this one for ease of understanding. I hope you can see that. Perfect. So we already have renal arterial vasoconstriction. Now, I need you to remember this. In the anatomy of the nephrons and the kidney, this part you can see here. Let me just move this away. This part you can see here, this is part of the proximal convoluted tubule, and it's called the S3 segment of the proximal convoluted tubule. And of course, this is the thick ascending loop of Henle. Now, the S3 part of the proximal convoluted tubule and the thick ascending limb of the loop of Henle are actually in the medulla compared to the cortex. Now, at any one point, even as we sit and talk right now, the medulla is relatively hypoxic compared to the cortex. So any disruption, remember, we have the RAS activated, vasoconstriction activated, it affects the medulla more than the cortex. Now we have here endothelial injury, and then increased adhesion molecules as expected in any vasculature. And then we have increased vasoconstriction. So what's the net effect? When you have increased vasoconstriction, now you end up having tubular injury, okay? Tubular injury. And what happens is that you have the pro-inflammatory chemokines that have come there, and there's leukocyte infiltration, and there's a release of reactive oxygen species, and all these cause damage to the cell and the microvilli, and they undergo necrotic cell death. Now, remember, I've already mentioned to you there's apoptosis, there's autophagy, and the others. All those are energy dependent. Necrosis is not energy dependent, it's basically just phosphatase dependent. But importantly, notice here, because there is very little oxygen and very little ATP, there is a mislocation of the sodium-potassium ATPase. So instead of being on the apical side, it goes to the luminous side. Now, this has an effect. Let me see if I can draw. Yes, let me see if I can draw. Okay, I can't draw. Anyway, around here, there's normally another protein. It's called the cry protein, CRRY. Yes, immunology can make you cry at times. But cry basically stands for complement receptor protein Y. Basically, complement receptor 1 protein Y. So with the translocation of sodium potassium from this side to this side, this complement protein that's supposed to be here is also translocated. Now, that protein is supposed to make the complement system, specifically the alternate complement system, to be at bay. Now, once that one is removed, complement system the alternative complement system gets activated, and once it is activated, it ends up forming a membrane attack complex, and you end up forming a lot of holes in the tubular cell. And you see, at the end of the day, you have at the end of the day, you have cell death. And that's why you see here, if we are to look at this diagram here, there's cast obstruction because you have increased intraluminous sodium and you have polymerization of the term-sulfur protein, and therefore they just mix with the sodium and you end up with a sludge. And that's why if you do microscopy in acute tubular necrosis, you see casts, and this is how some of the casts are made. Okay, so let's move to the next one. So remember, if the kidney is injured, sometimes you inadvertently end up having other consequences, yeah? So cardiac and pulmonary consequences of acute kidney injury. So remember this, the organs are in the same inflammatory or pro-inflammatory milieu, and they're communicating with each other. So it's not like one organ is alone and the other is fine. No, they're communicating. So if you have acute kidney injury, with oliguria, increased serum creatinine, positive biomarkers of kidney injury, and electrolyte disturbances, you can have a type 3 cardiorenal syndrome. Remember, there are 5 cardiorenal syndromes, and it's very simple. Cardiorenal, as it sounds, cardiorenal. Therefore, 1 and 2 is the heart affecting the kidney. 4 and 5, it's a kidney affecting the heart. And the difference is that one is acute, another is chronic. So you have an acute kidney injury, and therefore you have a type 3 cardiorenal syndrome. And due to the cardiorenal syndrome, you have a cardiac arrhythmia, diastolic heart failure. This is very important. Systolic heart failure, and even at times a myocardial infarction. Now, also, because of impeded renal recovery, you have a knock-on effect on the lungs. You have lung edema, respiratory distress, and hypoxemia. So they're all interconnected. So next, move to the next one, lung injury. So basically, we have seen that everywhere the endothelium is activated. So it's not limited even in the lungs. So endothelial injury in the pulmonary vasculature during sepsis disturbs the capillary flow and enhances microvascular permeability, resulting in interstitial and alveolar pulmonary edema. And that is why, amongst many other reasons, if you look at the sepsis, at the new sepsis guidelines, initially they say, yes, give 30 mils per kilogram of fluid. But if you need to give more, you have to give albumin. You have to give your albumin to keep the fluid in the vessels, because there's already a general capillary leak syndrome and it will go into the lungs. Classic in ARDS, where actually they prefer a restrictive resuscitation strategy. But also, neutrophil entrapment within the lungs microcirculation initiates and or amplifies the injury at the alveolar capillary membrane. And remember, I've already mentioned to you that the neutrophils are actually living longer than they should. Therefore, they're continuously picking up all the damage and everything, and therefore they just continuously cause more damage. So in the GI, the good thing, we have a presenter next week who is going to deal with the microbiome. Therefore, I'll just mention something very small. The circulatory abnormalities are typical of sepsis, may depress the gut's normal barrier function, allowing translocation of bacteria and endotoxin into the systemic circulation, possibly via lymphatics rather than the portal vein, and extending the septic response. And that's why, again, due to many reasons, it's very important to start early enterofeeding. If you don't do early enterofeeding in sepsis, you just you will, I don't want to say aid and abet, but just know the whole process of translocation will be worse, and it will worsen the whole picture of infection and inflammation. Then the liver, the reticular endothelial system of the liver normally acts as the first line of defense in clearing bacteria and bacteria-derived products that have entered the portal system from the gut. Liver dysfunction can prevent the elimination of enteric-derived toxins and bacterial-derived products, which precludes the appropriate local cytokine response and permits a direct spillover of these potentially injurious products into systemic circulation. So just know the liver is a big detoxifier. If it's not there, even some of these products, they just end up spilling over and they cause problems. Then the nervous system. Now, it's not very clear here, but let's see. They're saying the most common CNS complications are altosensoria, and that's very common, especially even in patients with septic shock. So the pathogenesis of encephalopathy is poorly understood. However, they're suggesting that CNS dysfunction has been attributed to changes in metabolism and alteration in cell signaling due to the inflammatory mediators, as we have seen with the others. But then also there's also a dysfunction of the blood-brain barrier, probably contributes, allowing increased leukocyte infiltration, exposure to toxic mediators, and active transport of cytokines across the blood-brain barrier. Remember, the blood-brain barrier is it doesn't allow anything to pass through apart from water. But when you have inflammation and these things are opened up, for example, actually, the classic one is in malaria. Malaria, you have terrible malaria, which ends up activating type C protein at the endothelium at the blood-brain barrier. And this literally ends up opening the tight gap junctions of the blood-brain barrier in the brain. And therefore, water enters and you get that is one mechanism of cerebral malaria. So in summary, as you have noticed, that the immune system is the major culprit here. You have an infectious process coming to your body. The immune response goes in a way that is not expected due to many factors. Could be the pathogen, could be the host, could be many other things. And it is basically the response to the infection that is causing organ dysfunction. In multiple times, you have seen us going back to the inflammatory or anti-inflammatory mediators that explain what is happening. So basically, that is sepsis. And yes, I think we have forgotten the Krebs cycle pathway, but maybe next time. Thank you very much.
Very well done, Dr. Kavata. Thank you very much for your presentation. Yeah, I know that we've taken a while on this, but this is the basis of what we are going to be discussing for the next 3 weeks, understanding pathophysiology. And Dr. Kavata took us back to the immunology class, dug us from there right to the physiological side of things, and now we know how things can go haywire. Do we have some questions? Dr. Preach, perhaps just a little bit of if you could just add on to your talk by talking a little bit about muscular physiology, as well as nutritional changes that follow the whole septic storm that follows what you just discussed. Could you just comment on that, especially in regard to lactate as well as the pro-catabolic stage of illness?
Okay, thank you very much, Dr. Erasmus. So I think let me start with the muscles. Now, okay, so we have seen that as a result of the excessive endotoxemia, you end up having a state whereby you are basically breaking down. Okay, you have an endotoxemia, therefore you end up with hypotension. Now, hypotension activates the renin-angiotensin-aldosterone system, and later you end up with general vasoconstriction. So that's one mechanism. Now, when you have general vasoconstriction, the body is trying to maintain the major organs, and the major organs to the body is the brain and perhaps the heart. And therefore, there is actually a lot of vasoconstriction from the skin and from the muscular system. Therefore, they are not very well supplied. And that's actually the reason why, if someone has sepsis and has septic shock, it will be very beneficial if you intubated that patient for a very simple reason. The muscles are already hypoxic because of the general vasoconstriction. The patient is hyperventilating, and therefore the cost of breathing increases exponentially. Therefore, by resting the muscles, you actually inhibit more lactic acid production. That's the explanation I'd have. Concerning feeding, remember in the diagram of the Krebs cycle I showed you, when the epinephrine is activated, it ends up activating gluconeogenesis. So sepsis is basically a catabolic state. You're breaking down everything simply because you need the energy that the body is expending at a very high rate. And therefore, if someone is in a catabolic rate, I would think in the initial hyperdynamic stages of sepsis, someone needs to be given a high caloric input to be able to counter the expenditure that is already out of what it is already more than what the patient is having. Yeah, thank you.
All right, thank you very much. I guess, again, I'm just trying to build on to some of the aspects of what shall discuss later. The next question I would like to ask would be aspects related to red cell physiology, bone marrow function, basically, and then endocrine function in relation to sepsis, especially in terms of procalcitonin and the like.
Oh yes. Okay. So something to mention about the bone marrow, for example. Remember we said part of the inflammatory milieu cytokine that is produced is TNF-alpha. Now, TNF-alpha, amongst other things, it's known to actually go and suppress the bone marrow. And therefore, that's why sometimes people who have chronic inflammation, some of them end up with anemia. But the mechanism of anemia, it's a bit different. But excessive inflammation has been shown to suppress the bone marrow. Concerning, you said procalcitonin?
The endocrine function.
Yes, the endocrine function. Okay, the endocrine function, if I could reiterate, basically we have the neuroendocrine pathway. The first pathway that we have had, where we have seen that if you have excessive inflammation, amongst other things, the pituitary will be activated. And once the pituitary is activated, actually it's a vagus nerve that ends up activating the anterior pituitary gland, and you end up producing adrenocorticotropic hormone, which goes to the adrenals. It produces cortisol, and this cortisol goes and inhibits inflammation. That is one pathway. The other pathway of the neuroendocrine pathway, of course, it is the renin-angiotensin aldosterone system, where you activate the noradrenaline and aldosterone. Therefore, you end up retaining water and solids, and also you end up with increased catecholamines in the body. The other one, actually, you end up in the endocrine pathway, you end up with a picture of a sick euthyroid syndrome. Now, a sick euthyroid syndrome, basically you have a normal TSH, a normal T4, and a reduced T3. Basically, it's an inhibition of T4 to T3 conversion. Remember, we have already said there's an increase in cortisol production. Now, cortisol has been shown to inhibit the conversion of T4 to T3. So you can get sick euthyroid picture. Of course, if the adrenal gland is involved in the pathophysiology of disease, for example, in meningococcemia, where you have Waterhouse-Friderichsen syndrome, where you bleed into the adrenal, therefore you not produce steroids, and therefore you can actually end up with refractory shock. That's why in meningococcemia, amongst other things, you really need to give your steroids if someone is hypertensive, because you're already thinking they have a Waterhouse-Friderichsen syndrome. Also in TB, for example, when the adrenals are perturbed by the mycobacterium, you'll also need to give steroid. And that's why in the guidelines, amongst other things, they say if someone is on vasopressors and they're still not responding, you can add a steroid, because there are many other factors that could be going on, and you just need this small kick of steroids to help you. Thank you.
All right, thank you. And now I see some questions have come up already, and Dr. Cornelius is helping answer them. That's great. I wanted to kind of clarify on, all right, I guess also what I want to just talk about is that, through the activity of interleukin-1 and interleukin-2, so interleukin-1, TNF, there is dysfunction in the parathyroid glands. and the the thyroid gland, which again lead to release of a number of hormones to get the calcitonin pathway getting activated and really releasing calcitonin as a pro-hormone. So that's really where the use of procalcitonin comes in. I guess beyond the scope of what we're going to discuss right now. Dr. Bashir asking regarding early feeding in septic patients, what about the GCS law, or shall we still feed them through NG tube? How about TPN? Thanks for the good presentation. Dr. Preach?
Thank you for the question, Dr. Bashir. So as I've mentioned, feeding in sepsis and in any critical illness is very vital because many times patients are in a catabolic state. Now, specifically, they encourage early enteral feeding. However, there's a caveat. If someone is on vasopressor support, they encourage you to delay the early enteral feeding for a very simple reason. If you do early enteral feeding and you're on vasopressor support, what will happen is that you can actually end up with a sort of a dynamic ischemic necrosis of the gut. Therefore, you have to individualize the treatment to your patient, what's happening at the bedside. Concerning total parenteral nutrition, it's a good idea, but it is usually associated with increased infection, especially catheter-related bloodstream infections. And that's why they say perhaps you could wait up to 7 days. After 7 days, if you're not going anywhere, then you could do early enteral feeding. You could start enteral feeding. However, sometimes I think in your critical care practices, you've all seen that a patient comes in when they're already malnourished and they're on very high vasopressor support. And again, you have to go back and individualize the treatment considering all these factors which I've mentioned. Thank you.
Thank you, Dr. Preach. And could you help Ismail understand the role of vitamin D in the pathophysiology of sepsis, as they saw it being used a lot in COVID-19 pandemic?
Thank you very much. Yes, it's among the many medicines that were used. So the whole idea is that vitamin D is actually thought to activate and enhance the phagocytic functions of macrophages and antigens and other phagocytic cells. Now, a classic example is this. Now, if this story I've been hearing it for long, and there's actually some medical literature, you could look it up. If someone comes in, for example, if we have the Muslim ladies from Saudi Arabia, they wear a whole burqa, and then they go to, let's say, Iceland, which has very little sun, but they're still wearing their whole full covering. Therefore, there is even very little vitamin D they are getting from the covering. They've been shown actually to have increased TB reactivations compared to people who are just in the sun. So vitamin D, the idea of using its function in infection has been there for a long time from these simple observations, but immunologically, vitamin D activates and enhances the phagocytic function of immune cells. Thank you.
I guess, Dr. Preach, the question will now be whether, we're using quite large amounts of vitamin D. We know vitamin D is fat soluble, and therefore the depots might last quite a while for a patient. And the question is, at what point does a previously previously well-nourished person who's critically ill, at what point would they get vitamin D deficient enough to require active replacement? During COVID, nearly everybody who had diagnosed with COVID was given some kind of vitamin D, and the question is whether we're merely making expensive urine and expensive food.
Okay, thank you for that question. So I'll try to answer it with an explanation of the vitamin D physiology. So usually once you're exposed to sun, vitamin D3, so basically sunlight activates vitamin D3, and then you go through your whole process to form the 125 hydroxy D. And that is what is actually, it's a 25 hydroxy vitamin D that is measured in blood, and then the other goes in urine. Now, think about it. We are people of color, meaning we are pigmented. People of color, compared to Caucasians, actually have less vitamin D compared to the others. So if anything, we are starting at a handicap. Yeah. So if you're starting at a handicap and someone comes in and very sick, ideally, I wouldn't give vitamin D because if anything, we are always already at a handicap compared to people of like because of our thick melanin. That's how I say it. And that's why, amongst other things, there are trials which have been done and they've not been shown to be effective. And that's why the sepsis guidelines is actually very silent about any use of any immune modulatory substances, including and not only excluding vitamin D.
All right, thank you. Dr. Lawrence, this will be the second last question. I'll be taking the rest will be answered in the chat. Dr. Lawrence is asking, says metabolic acid combination into the Krebs cycle and large amounts of lactic acidosis versus hyperventilation, pushing out carbon dioxide and metabolic alkalosis. So does pushing sodium bicarbonate help these patients? Dr. Preach? I guess this is a question preempting the resuscitation aspects.
Yes.
And maybe
Yes.
that's to help Dr. Preach briefly here in advance. In a few weeks, we shall be going into the hemodynamic aspects of management of our patients in the ICU. We shall delve deeper into the nitty-gritty of choices of different interventions. But Dr. Preach, specific to this question.
Thank you very much for that question. Now, if someone has lactic acidosis, it's a type of increased iron gap acidosis. And if you have because remember there are two types of lactic acidosis. We have type A, type B, and type D. So type A lactic acid acidosis usually happens when you're hypovolemic, okay, and you're hypoperfusing, therefore you form more lactate. Type B is not related to anything to deal with hypoperfusion, and type D is in people who have like short gut. Okay, so you're very sure, okay, it's not the others, it is type A lactic acidosis. However, they have an increased iron gap metabolic acidosis. And one of the tenets of management of an increased iron gap metabolic acidosis is to correct the underlying pathology with the hope that that will actually correct the lactic acid use. Therefore, unless in very severe metabolic acidosis, less than 7.0, usually increased iron gap acidosis, I wouldn't give any lactate. But also remember this, when you give your sodium bicarbonate, at the end of the day, it ends up being converted to carbon dioxide and water. So if you do that and you're not ventilating a patient very well, what will happen? There'll be increased carbon dioxide retention in the body, and it will just compound everything. But then also these patients are they're at high risk. Some of them are hypovolemic, and you give them your sodium bicarbonate, you may just want to worsen the already hypernatremia that is happening. Therefore, because I'm thinking that is an increased iron gap acidosis, I would try to first correct the underlying problem before delving into replacing the lactate. Thank you.
All right, thank you, Dr. Preach. This final question is regarding the inflammatory response to infection or in sepsis, the pro-inflammatory versus the compensatory anti-inflammatory aspect. Could you make a comment on that?
Thank you. So initially, it was thought that the inflammatory and the compensatory anti-inflammatory response, or the anti-inflammatory response, occur in tandem. Tandem basically means one happens, then the other happens. Basically, there's a time difference between the two. But now it has been shown that actually both of them happen at the same time, although one could be more pronounced than the other. Now, concerning the compensatory anti-inflammatory response, you can actually determine it by the bedside by using many different types of measuring. Amongst them is measuring the monocyte HLA-DR expression. The whole idea is that if you have a monocyte HLA-DR expression less than 15,000, you have moderate immune suppression. If you have a monocyte HLA-DR expression less than 5,000, you have immune paralysis. And therefore, what basically that means is that once the monocyte sees a bacteria, it will not be able to engulf it and present it through the HDR receptors to interact with the T cells and other cells. And that's why it is a paralysis of the immune system. Yeah. So the compensatory anti-inflammatory response can be determined at the bedside by looking at things such as the monocyte HLA-DR level. The pro-inflammatory phase, there are very many markers for that. For example, the C-reactive protein. Remember, the C-reactive protein is produced by the liver, but the precursor of, or the instigator of the producer of the C-reactive protein is interleukin-6. And that's why it's a correlate of the other. Interleukin-6 is a, CRP is a correlate of interleukin-6. So if a patient comes in and they're quite sick and you measure their C-reactive protein and it is high, you'd think perhaps interleukin-6 is increased, therefore pro-inflammatory state. But if their interleukins, if their CRP is not increased and you have access to, it's quite tedious, but if you have access to measuring the monocyte HLA-DR expression, it's less than 15,000, you know there's a compensatory anti-inflammatory response. If it is less than 5,000, it's a complete paralysis of the immune system. That's a severe immune suppressive state. Therefore, the microorganisms in the body will continue replicating unchecked. Thank you.
All right, Dr. Pritch, thank you very, very much for this talk. I would like to draw it to a close now and just again take us to give us a bit of a breather that leads us to the next talk. There's going to be a poll question on diagnosis sepsis. We're going to be looking at the diagnostic aspects of septic, sepsis and septic shock. So here we go. We have about 30 seconds to respond. So which of the following would be appropriate immediate steps for patients admitted to hospital with sepsis? Your blood cultures, CT brain, immediate transfer to ICU, resuscitation with human albumin. Which one is the most appropriate? Okay, so the response is coming in. I'll stop the poll when 50% of you have responded, or when our time has elapsed, whichever is earliest. Okay, so we've gone just close to a minute or so, and I have almost 50% of you having responded. So in 3, 2, 1, I'll end the poll. About 7% of you think you should immediately perform blood cultures in this patient. About 19% of you would like to transfer the patient to the intensive care unit immediately. And just 5% think resuscitation human albumin is appropriate. Nobody wants to see CT scan on these patients. So let's find out. We've got a presentation coming up soon, and Dr. Pritch will be responsible for the questions on the pathophysiology of sepsis in the chat. So if you still have some questions on pathophysiology, kindly get in touch in the chat and ask your questions there. So then our next presenter is another fellow of our scale critical care program. This is Dr. Claire Barker. She's an anesthesiologist and who practices currently at Coagulopathy Hospital, where she runs both perioperative medicine as well as intensive care, and she has a special interest in critical care medicine. Dr. Claire, could you share your slide and take us through? Thank you. Over to you.
Thanks, Dr. Erasmus, for the
Dr.
for
Claire,
moderating.
the floor is yours.
Can you hear me?
Yes, we can hear you. Please proceed.
Okay, thank you for the introduction. So I would take you through diagnosis of sepsis and septic shock in less than 5 minutes. Mine is a bit easier. Okay, Preach, could you please go to the next slide? Diagnosis of sepsis and septic shock begins with history. So when a patient presents to you, you have to elicit some history at the same time as you're resuscitating the patient. So it should be initial, brief, and it shouldn't affect the resuscitation phase. And most of the history is going to be non-specific findings, really, that but you should always look out for history that will point to the suspected source of infection. Maybe if a patient has had a cough or chest pain, fevers, so you should always try to find out which organ has the source, is the source of infection. You should also elicit risk factors, which include age more than 65 years, any immunosuppression state, like in liver, renal disease, HIV, malignancy states, and also some genetic factors. The other thing is you should also look out for history that shows that is likely to point out the severity of sepsis. For example, if a patient has had oliguria, altered mentation, this should point out to the severity of sepsis. And your assessment or clinical evaluation, examination, again, you may find very many parameters that are non-specific, but it's important to tie all that up. And there's quite many tools that have been out there that can help with the identification of sepsis. Again, this assessment will help you with there could be signs of severity of shock, of organ dysfunction. So it's important that you elicit all that. Next slide. Yeah, so there are different, quite many tools for screening for sepsis. And some of them we use in most of our critical care units here, and some probably we don't use them quite frequently. And they include SARS, Q-SOFA, SOFA, Muse, STAS modified early warning score. And it's important, most of these are used in different or various locations, could be the ward, the ED or ICU, again, depending on the factors that, the parameters that you could easily assess in that location. And they have a wide variation in sensitivity and specificity of sepsis. So you have to keep that in mind. The most common tools are Q-SOFA and Muse. However, the Q-SOFA helps predict death and prolonged ICU stay in patients. And most recent guidelines actually recommend against using Q-SOFA compared to SARS, Muse as a single screening tool for sepsis or septic shock. So remember, you shouldn't be using all these tools alone. So the other thing is these screening tools are probably not going to help a lot in some special populations like pregnancy, because the physiology of pregnancy is different, and basically normal pregnancy parameters overlap with the criteria for sepsis. The other special population is patients with COVID-19. So patients critically ill with COVID-19 satisfy the diagnostic criteria for sepsis and usually exhibit a phenotype and pathology with both similarities and differences to that of sepsis. Yeah, so it's important to know that in these special populations, you cannot exactly use some of these tools. So it's also, there's so many, I did not mention all of them, but QSOFA per se, since these parameters can be assessed in the ED, you don't need to do lab investigations, you don't need to do imaging or whatever. So QSOFA is actually ideal for an emergency department because these are clinical parameters that you can actually assess. While SOFA requires that you have done laboratory investigations, and also it's ideal for in-hospital and ICU. So you also look up the rest of the screening tools as well. Let's move to our next slide. Yes, so there are a variety of investigations that you can do in a patient with suspected sepsis. And again, most of these laboratory features are non-specific and may be associated with abnormalities due to the underlying cause of sepsis or to tissue perfusion or organ dysfunction. So for example, if you can do a complete blood count and differentials, and you're likely to get, leukocytosis, leukopenia, neutrophilia, thrombocytopenia. Again, these may really be non-specific, but they'll probably show you that there's an immune response, and your cell, probably you have your body is trying to respond to an infection. So the other things, you're likely to get hyperglycemia in most cases. So your blood glucose is important to take. Plasma CR protein, again, in any inflammatory state, that C-reactive protein is likely to be very high. You can do an ABG and it will give you, from the pathophysiology, you can have hypoxemia, you can have a respiratory acidosis, metabolic acidosis, you can have anything. So, but that helps you to tie up all your findings. Coagulation profile, in most cases from the pathophysiology, your INR is likely to be higher than 1.5, it to be higher. Just like Dr. Preach explained how sepsis affects the coagulation. You should also go on to do other tests that are specific to different organs. Since sepsis is a multi-organ, it's a systemic disease and usually can affect more than 2 whatever organs. So you should do renal function tests, liver function tests. So also look out for other for adrenal insufficiency, especially in patients who are presenting with shock. Should do serum lactates. Serum lactate more than 2 is obviously, like he mentioned, it shows that there's hypoperfusion, and most likely it's going to be in patients who are in septic shock. Yeah, so yeah, then the other laboratory biomarker is mid-regional pro-adrenomedulin. This is it's basically a biomarker. It's a peptide that's generated from by the multiple tissues in order to stabilize the microcirculation, and it helps to protect against endothelial permeability. So this is one of those, I think, newer biomarkers that have been used in sepsis, and it helps to predict occurrence and worsening of organ failure in critically ill patients. Next slide. Next slide, Preach. Okay, so the other lab investigation that you can do is serum procalcitonin. And studies have found that there's poor evidence on its diagnostic value, but it's helpful in de-escalating antibiotic therapy. Yeah, so it also does not really distinguish sepsis from non-septic systemic inflammation, but yes, it only really will just help on de-escalation and duration of the antibiotics. And the recent guidelines or recent recommendations against the use of procalcitonin plus clinical evaluation on the decision to decide when to start antimicrobials as compared to a clinical evaluation alone. So again, important to note that it's not one of those things that you should do at the start just before you give your antibiotics and all, but it will just help you eventually. And the next one is serum lactate. So serum lactate, elevated serum lactate is part of the sepsis 3 definition of septic shock. And again, the recent guidelines suggest measuring blood lactate, and it's been associated. There's an association of the lactate level with mortality in patients with suspected infection and sepsis. Yeah, so it's quite important to have the serum lactate. So imaging, again, for imaging, this really helps with looking out for the infection in a specific site. For example, pneumonia on a chest X-ray, fluid collection on a CT scan. And you can do imaging anywhere. It could be, the rest of your body to look out for the infection. Yeah. So microbiology. So this includes blood cultures and the rest of cultures. Anything, could be urine, could be sputum, could be so many other things. So this helps with identification of a specific organism. And remember, if it's for peripheral blood cultures should be taken from at least 2 different sites, and should be both aerobic and anaerobic cultures. And remember that from research, again, a culprit organism is frequently not identified in up to about 50% of patients. And again, there's a study that was done, and all patients who had 2 sets of blood cultures drawn from 2 separate sites before antimicrobial administration, and a second set obtained from 0 to 4 hours after antimicrobial administration. When they compared those 2, they found out that the pre-antimicrobial cultures were positive in 31.4% compared to the 19.4% in post-antimicrobial administration. So it's recommended that cultures should be taken off before antibiotics are administered. Thanks for listening. That's the end of my presentation.
All right, thank you very much, Dr. Claire, for your presentation. Yeah, so I guess this is the practical part of things, and now really what we do, get a patient, suspect the patient has an infection, or you know the patient has got an infected site somewhere, and then they meet certain criteria, so you label them septic. It's unlike the definition of some of those old books some people still have in their drawers that says sepsis was basically bacteria swimming in the blood or pus swimming in the blood. It was quite a horrible way to express it. So over to the audience, do we have questions for Dr. Claire on the diagnostic aspects of sepsis and septic shock? Maybe Dr. Claire, if you could just walk us through a case. Let's say someone walks into your office, or walks our office, yes, I see you. Someone walks into the hospital and you know, they have well, they have infectious symptoms and they're having a fever and the like. How would you go about making the diagnosis, just practically, you know, so that everyone gets a mental idea of the flow of action?
Sorry, Dr. Rasmus, I didn't hear that. I'm sorry. Could you please repeat?
Yes, I wanted you to just walk us through mentally what you would do when, if a patient walked into the hospital or was rushed to the hospital, and you know, the process of getting the patient, seeing the patient, make a decision on whether it's sepsis or not, and ultimately, you know, making the relevant investigations. How would you do that?
Okay. Thank you. I actually thought I sort of simplified my presentation to sound a little bit more practical. So yeah, so when a patient comes in, maybe to the ED or to the hospital, in most cases, your approach should be if they don't have any airway issues or respiratory issues, again, ABCD approach is very important because you cannot move to looking out, taking a brief history and all, and when a patient actually requires initial resuscitation. So depending on how they present to you, while you're resuscitating, it's important that you take a history. Now, it could be a collateral history if a patient maybe has altered mentation or for any reason it's not able to give you the history. So while you are resuscitating, it's important that you take a brief history, like we mentioned. Look out for any of those things. Is there any history that's suggestive of maybe the way whatever they're presenting with? They could be having respiratory distress. You're probably going to focus on, you know, was there cough and all, or does the patient have like cellulitis? So meanwhile, as you're taking that history, you're taking your vital signs, and so concurrently you also do a clinical examination. So that again will help you know the suspected source of infection, and you would have also elicited risk factors, and then also severity again from symptoms and clinical signs. Sometimes it's straightforward. Sometimes you may not exactly know the source of infection, so you do you know, basic laboratory investigations and imaging. If you suspect, for example, you have maybe sepsis from you know, from the abdomen, probably you can do a CT scan or whatever. So again, I think ideally it should really flow, and you look out for all those things and do baseline investigations and then specific investigations. But again, remember there are tools that that we mentioned that are able to to tell whether a patient with a suspected infection is on their way or they're developing sepsis. Again, you can use any of those tools, and you put all your clinical variables together and identify those patients quickly who have sepsis or are likely to develop sepsis. And the moment, so we've talked about different investigations to do, imaging, cultures. But remember, if you think your patient has sepsis, you have the 1 hour band. I feel like I'm going to management of a patient. The things that you should do within a few hours. So blood cultures, again, like we mentioned, you should take off before you begin antibiotics if you think the patient actually has sepsis. The serum lactates should also be done. Remember, if a patient is in shock, then the management also is different. So some patients that you need to start, after putting, of course, IV access should be put right from when you're taking history. Yeah, I don't know, Dr. Erasmus, if I've answered your question.
I see you're going to management. So yeah, I guess I should stop you. And that's the challenge with sepsis. Being an emergency, every aspect is intertwined. You're talking about recognition, at the same time you're talking about investigation, as well as the aspects of management. I guess what I wanted to, you've mentioned what I really wanted to hear. So basically, patient walks in, you need to know how to identify that they are infected. So that may be from the history, that may definitely be from the examination as well. And that will help you to definitely know which area is infected clinically. It might also direct you on further investigation that you might need to do, especially to establish the source of infection. Then after that, so in other words, either you determine the patient has got an infection, or the patient has got, or you suspect highly the patient could be infected just from their symptomatology. Then the next thing is to establish if the patient is septic. Infection is different from sepsis. So to establish the patient is septic, you want the most signs of organ dysfunction, which you may accord to that dysfunction or this dysregulated immune response that Dr. Preach talked about earlier on. So simple tools do that. Clinical tools include things that can stratify a patient by severity. So Acute software works in that area to screen patients who are likely to be of high mortality, to have a high mortality if they have an infection. Basically, now they have dysfunction of organs. So that's why you go ahead and use things like, the Acute software, so rate. Once you have that, you're able to identify patients who are definitely sick and direct them to better areas of care where appropriate care may be given. Or if you don't have the resources, you might be able to escalate into aggressive mode of care. You go to beast mode as a doctor to try to rescue that patient in time. The rest of the workup, I guess, talk about cultures, to identify the type of germ. So frequently one type of blood cultures, but also based on the clinical assessment, you may want to go for a site-specific culture, which may be PASS if the patient PASS. Somewhere in the sample, in urine, it might be depending on people go by people go by protocol and they implement batteries of investigations, which include investigating in sites that may not be actively infected. So you have to think about the cost of care along that. So going to the chat, there are some questions. One question from Dr. Adem Acheng. Which is the best screening tool for children? I suspect Dr. Cheng is a pediatrician or a pediatric resident. Dr. Claire, Do you have a tool or guidance for the pediatrics practitioners on what to use?
Dr. Erasmus, I did not come across that. I didn't actually pay attention to the pediatric.
All right, thank you. Dr. Acheng, I guess hopefully one of our pediatrics gurus joins us sometime. They are quite busy in theater doing some more some work. But generally, it's important to appreciate, as is a commonly preached rule, that children are not just small adults. They are quite different. A number of things that are quite easy to note in the adult definitely define children. Things like we are expecting hypotension. It's kind of delayed in children. We're expecting people to be having warm extremities and septic shock. Children might have to present with cold extremities just because their heart is quite thick cardiac output and the increased work of the heart from the increased work of the heart from sepsis the heart function. So they might present their cold, having cold extremities instead of so the sepsis may unmask septic cardiomyopathy in these children quite early. Interventions also given before the patient comes to hospital may have altered the situation for children. The other thing is there are clinical signs like tachycardia, tachypnea, may be mistaken for anxiety in children. So yes, I really feel for the pediatricians when it comes to determining if a patient is septic shock. However, some things are still universal. If a patient is going through hypoperfusion, particularly or having a dysfunction of organ function, there will definitely be a relative alteration in baseline. So you have a child who has got a febrile illness or has got demonstrated sepsis, demonstrated infection, ending up with altered alimentation. They're too sleepy. They are not feeding. They are vomiting a lot. You wonder what is disturbing that, and then the patient is ending up with reduced urine output. You examine the extremities, they are probably cold, they're having slow capillary fill time. Those are some of the clinical signs you can look at. They're fairly similar in terms of what exactly the impact of septic shock will be in the children. However, there's usually a delay in diagnosis of children for the reasons I mentioned because their presentation not very direct. Hopefully, I'll have a pediatrics intensive care practitioner or a physiologist chime in later on to give us a bit more guidance on the subject. And then the other question is Dr. Lawrence Kazigwe wishes to have Dr. Claire share a simplified criterion to be adopted by the Ministry of Health for General Hospital casualties at national levels. Meals and relating respiratory rate, BP, temperature assessment as related to our handy poll questions. I think Dr. Lawrence Kazigwe has an idea already on some of the things that he wants you to include in the simplified approach or algorithm that can be shared by means of health. As usual, we don't like to reinvent the wheel. So first, we probably have Dr. Barker look up any existing diagnostic criteria that the ministry might be having, and then we see how to improve that. It's definitely a very good call to have this conversation go to national level to improve care. So thank you, Dr. Claire. Do you have any other questions? We shall be having the presenters respond to the poll questions at the end of the chat. Yes. Dr. George Kalema, do you have a question? All right. So we shall quickly be moving to our next presentation. So the next presentation will be our last for the night, and that is initial assessment and management of patients with septic shock. Our next presenter will be Dr. Joyce Kalunji. Dr. Joyce Kalunji is an anesthesiologist, also very interested in Petropian, and is a fellow in our SCALE program. She will be taking us through the aspects of management in the initial phases. So, Dr. Joyce, could you share your slides?
Good afternoon, everyone. I hope you can hear me.
Yes, we can hear you, Doctor.
Okay, so let me share my slides. I had done it previously, but
Dr. Kalunji?
yes, I'm sorry for the delay. My computer is getting old. What have I done now? Sorry. Here.
Dr. Kalunji, we can see your slides. Perhaps if you just hit the slideshow button, you might start presenting right away.
Okay, I apologize, Dr. Asmas. You can all hear me. Hope the presentation will be better than the start. So yes, we are continuing to talk about sepsis. You can hear me, Dr. Asmas?
Yes, we can hear you clearly, and your slides are clear as well.
Okay, so we're talking about sepsis and septic shock, initial resuscitation and stabilization. Okay, so the mantra of sepsis management, I think for me, I would divide it into 3 steps. Usually you have to do hemodynamic management and then infection control. The hemodynamic management is largely done with fluid resuscitation. And if the shock is refractory to that, then you have to introduce vasoactive agents. Infection control is usually done with antimicrobials, usually antibiotics, antivirals, or antifungals, and you also have to do source control. And sometimes you have to use immune modulatory mechanisms. So the fluid resuscitation, of course, sepsis is largely an emergency. I largely focused this presentation on the guidelines for management of sepsis and septic shock, that came out last year, that's 2021. So the first thing that you do, of course, sepsis is septic shock particularly is an emergency. And usually if the patient who is in septic shock should be able to access the ICU within 6 hours of presentation to your hospital or all emergency room, because ICUs are better at sort of managing, initiating treatment and following up. So patients who are largely managed for septic shock beyond 6 hours in places other than the ICU usually will have poor outcomes. So we'll start with fluid resuscitation, which is the first thing you do. When your patient is in septic shock, like the one we talked about, was that gentleman in his 70s who'd had urinary symptoms, and he presented to the ED with a tachycardia, and I think a systolic blood pressure, if I'm to remember very well, of about 70 out of something, and was diagnosed with septic shock. So you should put 2 large bore cannulae. In this is you're referring to a gauge of about 16, largely in the cubital fossa, and you initiate IV fluid resuscitation, which is first line, usually crystalloids. Current recommendations are that you go for a balanced crystalloid vis-a-vis a 0.9% normal saline. Normal saline is associated with metabolic acidosis, and which large volume resuscitation with 0.9% normal saline is largely associated with metabolic acidosis and AKI. So balanced crystalloids like plasmalite and Ringer's lactate are generally preferred, especially for large volume resuscitation. So the dose, and it's an arbitrary figure, mainly which we have derived from retrospective studies. There've not been any prospective studies, is that you give about 30 mils per kg of that fluid within 3 hours. And this, of course, this type of, this is what we found to decrease mortality. So, and then you're going to evaluate your patient. I think we've talked about, you're going to evaluate your patient. This is particularly for patients with septic shock. You're going to evaluate your patient and see the fluid responsiveness. So if the 30 mils per kg is not effective, then you may decide to give extra boluses of fluids, about 3 to 4 mils per kg, but you're going to use goal-directed therapy, like we're going to see on the next page. So how much fluid in total are you going to give? Usually, I think it's a bit confusing for people after they've given the 30 mils per kg, and they're wondering how much fluid they will maintain the patient on. This is still a gray area for us. We are not really sure how like as an amount of fluid. It's really something that should be patient-centered, and it should be personalized care, and it's just based off the signs of perfusion, normalizing your lactates, doing capillary fill times, and measuring other dynamic features that help you to tell whether the patient is perfusing better. So the restrictive versus the liberal approach of fluid resuscitation, we are not sure how much in total the patient can receive. We are really not sure. So the other fluids, I think, that have been tried before, that's colloids, both the starches and gelatins. They don't offer mortality benefit, but they're associated with anaphylaxis and AKI. And essentially, they should largely be avoided. Albumin is very expensive. A bottle goes for about 400,000. 400,000 in Uganda. I've not adjusted it for the inflation. And according to the current evidence that we have, there is no mortality benefit of using albumin in resuscitation of patients with shock. But however, it usually comes in handy when people have received, for people who've received large volume resuscitation and are still hemodynamically unstable, because it evidently is associated with increases in blood pressure. So when you're giving your fluids, what are your targets? How do you know that the patient is improving as you titrate and give the fluids? Usually, one marker that we shall use will be lactate, which you get on your ABG. Your lactate is, normal lactate is usually between, largely below 2, so 1.6 to 2. And your aim is to largely reduce the lactate by about 20% for every 2 hours. The pathophysiology has been explained, so I guess we all understand how the lactate comes about. So that's one thing that you use during fluid resuscitation. Largely, you want to normalize your lactate. The other thing that came as a miracle, I think, for low and middle income countries is the capillary refill time is largely as accurate as the lactate. So in low middle income countries, or in hospitals that may not have the lactates, then you can use your capillary refill time to guide your resuscitation with fluids. I guess the trial that I think is the Andromeda trial. So what are your targets vis-a-vis blood pressure management? The target for blood pressure management is mean arterial pressure of about 65 millimeters of mercury, and we use according to the country recommendations, it's better to use invasive blood pressure monitoring. It comes with a very few side effects, and it's largely more accurate, and that's why it's recommended, although the recommendation is weak. So it also enables you to take off a number of ABGs if you use it as compared to when you use non-invasive blood pressure. So when you for hemodynamic monitoring during your fluid resuscitation and management of shock, it's better to use dynamic parameters rather than static parameters like blood pressure and pulse rate. Those are some of the static parameters, or urinary output. So the dynamic parameters are pulse pressure variation, stroke volume variation, thermodilution techniques, echocardiogram, and passive leg raise. So because most of us do not do invasive techniques, usually I think in our ICU now we have a point of care echocardiograms, and we can evidently perform the passive leg raise as well. So the next hallmark is antimicrobials. So let's talk about antimicrobial therapy. So the antimicrobial therapy should be initiated within the first 1 hour of the diagnosis of septic shock. So you take off the blood cultures and then you initiate your antimicrobials. Without shock, you can defer the antibiotics for up to 3 hours, and that's essentially to confirm that there's an infection, because unfortunately there's so many differential diagnoses of sepsis. So usually in these 3 hours, you're just trying to avoid initiating an antibiotic or an antimicrobial for something that is not, it may not be an infection as such. So you take off site-specific cultures, and then you will initiate your antibiotics. So for antibiotics, which type of antibiotics are you going to initiate? It is very important to take an antibiotic history, and usually taking an antibiotic history largely means you need to take the history from the patient, understand what are the symptoms. That will give you a view of what the source of infection would be. Sometimes there are so many largely non-specific infections, including malaria and the rest, but it can come in helpful. The other things you need to know is the patient's antibiotic history, whether they've been exposed to an antibiotic for the last 90 days, if there's been exposure to a healthcare facility or a nursing home, if the patient themselves have an invasive device in situ. For instance, you find people with dialysis catheters. Is the patient immunosuppressed? So like diabetics, HIV, and whether the patient has history of they've ever suffered from a drug-resistant bacteria. The patient that we had, I think, was a gentleman in his 70s with diabetes. I think diabetes. I don't know if I had psoriasis, BPH. He'd been in a hospital 2 weeks back, given antimalarials, but also at the time of admission, he'd had, I think, some a fluoroquinolone given to them. So all those things guide you, and I think that's why the team decided to initiate a carbapenem, because there was suspicion of probably a multiple drug resistant infection. Yeah, so after you've taken the risk factors, there are just some few recommendations that we can talk about, because antibiotics is literally a class on its own. So if a patient has risk factors for MRSA, then it is better to initiate an antibiotic like vancomycin that can cover MRSA. And if not, then it's recommended against initiating those antibiotics. Broad spectrum antibiotics, especially unnecessary ones, can end up giving patients antimicrobial resistant infections later on. So it's recommended if you suspect that a patient has a gram-negative MDR sepsis, then you should largely you should largely initiate 2 empirical antibiotics that can cover gram-neg. For instance, if you have a patient in the ICU, has been with you for a week, they have a VAP, you suspect it could be Pseudomonas, then it's just better to prescribe 2 anti-Pseudomonas antibiotics as gram-negative antibiotics. That's different from if a patient comes in with respiratory failure and they have a community-acquired infection, unless your local susceptibility patterns recommend that. So the other recommendations in septic shock is that the beta-lactams should be given as infusions versus intermittent boluses. Of course, if patients have low risk for MDR, then you should just initiate 1 antibiotic. With especially gram-negative sepsis, you can just initiate 1 antibiotic. The de-escalation of antibiotics, so it means you took off your cultures, you're going to continue to have antibiotic ward rounds, you review your cultures, and then you de-escalate. So when you're de-escalating, even for gram-negative sepsis, you can continue with 1 antibiotic as per your susceptibility information. So the de-escalation of antibiotics should likely be guided by procalcitonin and clinical evaluation. The duration for most antibiotics is still largely unclear, but about 7 to 8 days, especially for community-acquired infections. And as well, if the patient improves, then it would be better to de-escalate them from IVs to orals. Patients who are high risk for fungal infections, it's better if you initiate empirical fungal therapy. I thought that this, yeah. And then yeah, so for antivirals, currently we don't have any recommendations. The other recommendation is always to optimize your pharmacokinetics and pharmacodynamics. Usually these patients have, they're undergoing dialysis, the volume of distribution is altered. So it's very important to monitor your PK/PD. It could be one of the reasons why your patient is not responding to the therapy that has been recommended. Okay, so source control. So antimicrobials go hand in hand with your capacity to look for the source of infection, and largely control the source of infection. If you have a surgical site, so you have sinusitis that you need to do maybe aspiration or drainage, it's post-abortal sepsis with retained products, it's septic arthritis, it's an empyema, it's device-associated sepsis. You largely need to find the source of sepsis and get rid of it, otherwise your patient will not improve. This usually involves taking a good history and then involvement of a multidisciplinary team. Yeah, and you need to have continuous assessment. As my colleagues said, in over 50% of the patients, sometimes you find you have you had signs of infection, and you have maybe culture negative sepsis. So sometimes it's a gray area of where you should about continuing the continuing the antibiotics, but it largely requires continuous assessment and diligence. So another recommendation in management of sepsis is early initiation of vasopressor, vasoactive agents after giving of your IV fluids and the sepsis is refractory. We all know that as much as IV fluids will improve your perfusion, if they also have side effects that can range from capillary permeability and disruption to end organ dysfunction, delays in wound healing, and taking patients pulmonary edema and essentially iatrogenic pulmonary edema and essentially delays with mechanical ventilation. So the recommendations are that you will use noradrenaline as the first line vasopressor, and you initiate it and you largely target a mean arterial pressure of about 65 millimoles of mercury, milliliters of mercury. So mean arterial pressures of above 65 really offer no mortality benefit, but they're associated with users of larger doses of norepi and acute kidney injury as well. As I've talked about before, it's better to consider invasive monitoring. However, the current guidelines say you don't necessarily need a central line to start your vasopressors. If the patient is not well, you can actually put a large bore cannula in the cubital fossa and start your vasopressors. So the second line vasopressor is vasopressin, and that should usually be started when your norepi is about 0.25 to about 0.25 mics per kg per minute. Then you can start vasopressin. The other vasopressor that you can also initiate is adrenaline. Sepsis per se is associated with cardiac dysfunction and persistent hypoperfusion. So inotropes can also come in handy in management of Takotsubo. And in this instance, the first line is usually dobutamine, and you can also add or switch to epinephrine. It's largely clear. So other therapies that have been talked about, there's corticosteroids, that's hydrocortisone. Largely, these are supposed to be immunomodulatory therapies, although there's still a lot of controversy, but the current guideline is, especially about the mortality benefit, but the current guideline is that you should, hydrocortisone has shown more benefit in patients who are on vasopressors, on vasopressor therapy, who had been on vasopressor therapy. That's noradrenaline, particularly a dose of about 0.25 to 0.4 mics per kg per minute for about 4 hours. So largely it's a week recommendation, but the dose is about 200 milligrams per day. That's 50 milligrams divided into four doses for about 50 days. The other complications of sepsis are usually hyperglycemia, like as what happened in this patient. And in that instance, we will usually initiate insulin and insulin infusion. And the cutoff points are usually about a random blood sugar of about 180 millimoles per deciliter after you've gotten 2 consecutive values of hyperglycemia. So your target is usually to keep it within that range, about 140 to 180. Starting insulin for values below 180 are largely associated with hypoglycemia. The other things are usually concerning routine care, routine housekeeping. So VET prophylaxis should usually be prescribed, and what's recommended is low molecular weight heparin, except if there's a contraindication, and except if the recommendation is to use unfractionated heparin rather than low molecular weight heparin. Yeah, PPIs for patients who are high risk for upper GI bleeding, usually patients in shock, who are intubated, having acute liver injury. Yes, you should initiate a PPI. So of course, sepsis is usually associated with other complications. Sometimes one of the biggest complications is of course hypoxic respiratory failure. So you should always put the patient on oxygen. The target oxygen level, still controversial, but depending on whether the patient has ARDS, you may have lower targets like the ones of ARDS. Yeah, and not try to cause injury because you're targeting an SpO2 of above 97. So interestingly, they said a high nasal flow cannula was better than a CPAP for patients who require some form of non-invasive ventilation. Of course, the CPAP mask is not very easy to manage for these patients. It reduces the work of breathing better than the high nasal flow cannula, but it's associated with more failure. Because it's with I think because it cannot be well tolerated, but maybe largely the patient may be sicker, and so it's associated with a higher failure, higher intubation rates. If a patient has respiratory failure and they have shock, you should use the lung protective ventilatory strategies as they are well known, including non-depolarizing blockers, which should be given more as intermittent boluses versus continuous infusion. Proning, if indicated, should be done for over 12 hours, and ECMO in centers where it should be done. Acute kidney injury is also so it's not always, but there's a large degree of patients that will have septic shock that will end up with acute kidney injury. So the benefits of initiating renal replacement therapy are only preserved for those people who have an indication for dialysis. So fluid overload, refractory metabolic acidosis, refractory hyperkalemia, those are the people that you should dialyze. And according to the current literature, you can use CRRT or intermittent renal replacement therapy. Apparently, there's no mortality benefit. However, we know that there may be hemodynamic instability associated more with intermittent than with CRRT. So the other therapies, vitamin C offers no mortality benefit or vasopressor-free days. So it's not recommended. It's just an extra cost to the patient. Bicarbonate therapy, largely in patients with septic shock and metabolic acidosis, as explained earlier by my colleague, will not offer a metabolic acidosis with hypoperfusion and therefore hyperlactatemia. Usually the metabolic acidosis is high anion gap, so there's no mortality benefit here. However, there are side effects like hyperkalemia and rather hypernatremia and metabolic alkalosis. The benefit of giving bicarbonate therapy has only been seen and recommended for patients with acute kidney injury based on KIN category stage 2 and 3. That's when you can give some bicarbonate therapy as per the current recommendations. Yeah, so enteral nutrition, earlier on, there is no mortality benefit for early enteral nutrition. That is initiating enteral feeds within 72 hours of admission, that would be called early, and then past the 72 hours of admission, that would be called late. However, it's hypothesized that the recommendation is you should ideally initiate, unless there's a contraindication, you should initiate early enteral nutrition within the first 72 hours. Although there isn't a mortality benefit, enteral nutrition is still hypothesized to maintain gut integrity and to prevent intestinal permeability, dampen inflammatory responses, and insulin resistance. The downside is, I think, people who had enteral nutrition, according to studies that were used to make this recommendation, is they probably had more GI complications, a bit of nausea and vomiting, and a bit of nausea and vomiting. But largely in our setting, I think it works, and also it helps. It will prevent fluid overload because people may continue to give more fluids than are recommended. That's the end of my presentation. Thank you.
Okay, thank you very much, Dr. Joyce. So, yeah, I think I guess that's the beauty of building up from the beginning with a nice broad understanding of how the disease evolves, and now the rest of the talks just fit in perfectly. Yeah, I would like to welcome questions on the chat. Dr. Bashir Ahmed had needed a clarification on the vitamin, which you did. Lawrence is asking about albumin therapy for improving oncotic intravascular pressures for these patients. And then the role of amino acids in septic patients, or chances of worsening disease like we saw with alternatives to ATP production for the Krebs cycle. Any comment, Dr. Joyce?
So I haven't read up on any use of amino acids in sepsis particularly. Yes, initially it was hypothesized that albumin per se would help to increase oncotic pressure and largely maintain or improve hemodynamic stability without using lots of fluids. For the studies that have compared albumin, use of albumin and crystalloids plus crystalloids alone, I don't know whether it is the outcome, the primary outcome that has an issue, but usually the primary outcome is 30-day mortality, which albumin plus crystalloid vis-a-vis crystalloids alone does not improve. I think what the studies show is there's a mild improvement on what? There's a mild improvement in the hemodynamic stability. Maybe patients you'll achieve higher MAPs and use less fluid. But then we now talk about the cost of albumin and how much of the volumes you'd have to give. So I think that's where the recommendation would come in, that you should use albumin when absolutely necessary, and that is in patients in whom you have used quite an amount of fluid and you're at high risk of volume overload. That is my interpretation. Dr. Rasmus, you can, I think, help me. Okay.
All right, thank you. I think you did quite well with the answer. It's quite fitting. So I guess the issue is that we are always stuck with the captivity of a U box here. We're always trying to normalize numbers, and we don't really care about the pathophysiology of disease. We just want to see that that potassium is exactly as it should be in a reference range. The sodium is perfectly as it's supposed to be. And that's where we sometimes go wrong, because the process starts chasing our tails, trying to correct every number, yet we may not be earning a patient any more benefit. If anything, we're causing harm by direct impact of the intervention we're giving, or we are actually causing harm in view of the financial aspect of it. Regarding albumin and the oncotic pressure and the edema and the like, I guess if we understood the physiology of the basement of the endothelium, endothelial glycocalyx, and the hemodynamic profiles, the hydrostatic aspects of it, then the protein dependent part, we would probably understand a lot more where these things fall. The number of studies have actually looked at the oncotic pressure of patients who are hypoalbuminic in sepsis, and they found that they're not so significantly different from patients who are having a normal albumin. The reason, and healthy. The reason being that it appears the reduction in albumin is as a result of partly an acute phase reaction, with albumin becoming a fuel for breakdown and financing the activities of the immune system, but also albumin leaking out of the vessels, but being replaced by other proteins, particularly immunoglobulins, which kind of maintain that oncotic pressure quite significantly. So adding albumin may not necessarily achieve the effects you want, but at the same time, we have to remember that we are trying to chase our tails, putting in albumin to correct a number, but the pathophysiology of disease involves the activity of the immune system against an infection. And if you don't treat that, you're not achieving much. So definitely, like you said, albumin will probably help us to reduce the amount of fluid we need in a patient, but may not necessarily help us so much in terms of the hard patient-centered outcomes. Even you might hurt the patient financially. And given the disease is chiefly around stopping the trigger for the inflammation and supporting organ function, that money might actually go further in helping a patient live in terms of buying them the appropriate antibiotics they need and other interventions. So again, there is a tribe somewhere in North America where people have trace amounts of albumin, of albumin in their body. Genetically, they do not make albumin, and these guys have no trace of edema on them. So it kind of helps us to, it might help us to understand again that maybe dropping in things in patients doesn't really help much. Amino acids probably will serve for nutrition at a certain stage. Remember, in catabolic stage, in the early inflammatory stage of sepsis, everything is like to be driven towards gluconeogenesis and energy formation. So you may not necessarily help build the patient up by giving amino acids. Of course, if they are on a fluid, you could argue that maybe they have a little bit of, usually amino acids are dissolved in normal saline. So you're probably giving a patient a large dose of normal saline in the first place. So it's like fluid resuscitation, but again, an expensive intervention compared to just giving a patient either saline or Ringer's lactate. We're not going to start a war on which fluid to use, whether Ringer's lactate or normal saline. I think there's a question that on the poll, but overall, give patient crystalloids cheaper, it's effective and helps. Dr. Noah Mundago wishes to know on the issue of fluid resuscitation, 30 mils per kg, in what duration must I administer that volume? Dr. Joyce?
The recommendation says that the 30 mils per kg should ideally be given within 3 hours. But I guess maybe what you're trying to ask is that I think the flow of events, like when the patient appears in the emergency room or in the ICU, at what intervals are you going to give the fluids? My answer is that it should be largely personalized. It should depend on the patient and then the hemodynamic parameters that you're getting. I would say that maybe you would start, depending on the history you've picked from the patient and their comorbidities, that you can start with maybe giving about 1 liter of fluid, and then you would evaluate, you'd see if the patient requires more fluid based on your hemodynamic parameters, and then you'd continue to, I know it's a bit ambiguous, but yeah, you continue to give. But the recommendation is that it should be given within a span of 3 hours.
Well, actually, so this is more like a bolus that you want to give quite quickly. Of course, that volume must be given that quick period of resuscitation. Some people talk about the 1 hour bundles and the like. So the first question is, does the patient need the fluid? Is the patient in shock? That's the first question. So if the patient is in shock, you're establishing signs of shock through looking at the capillary fill time. You're looking at the mentation, urine output. Looking at other parameters if possible of the biochemical ones like lactate and maybe mixed venous oxygen saturation, among other things if you have those advanced investigations. Now, if the patient is septic, the next question is, will they benefit from fluid? In other words, if I give a patient fluid, will the patient tolerate the fluid, and will it likely increase their cardiac output? So you definitely need to go ahead and now investigate for that. Does the patient have fluid tolerance? So simple tests like a passive leg raise bedside, if you have a point of care ultrasound, you can look at the IVC, look at viability. The other thing that shall teach you maybe in future, when you go for dedicated talks on hemodynamic care of patients, that you can look at. And, if the patient's neck veins are kind of flat, they're hiding in the chest, sure, the patient's hypovolemic, give them fluid, reevaluate the parameters of perfusion. Remember, most patients who get septic have probably been starving for some time. They have been hyperventilating, they have been diaphoretic because of the fevers, and maybe they had diarrhea. So they're usually behind on the fluid. So it makes sense to give them fluid initially during resuscitation. Now, when you're given the fluid, you have to reevaluate because it has to go directly. You're looking for improvement in perfusion. Has the capillary time improved? Is the patient meditation better? Do you know if it's better? You know, if that's not it better, you repeat the bolus and reassess again. Of course, based on whether they're still fluid responsive. Sometimes you give fluid, like in our patient who was presented earlier on, you give fluid boluses, but the patient is not improving on fluid. So in that case, you might need to quickly introduce inotropes or vasopressors into the care of the patient, and that might help you better. You know, vasopressors work in multiple ways to improve the cardiac output and perfusion of patients, and that will be discussed in another talk that will come to you very soon. So early intervention with the steroids, with the vasopressors helps, and of course, if it's vasopressor refractory shock, then introducing things like steroids might help also. You know, we did talk about addition of calcium or something like resuscitation, among other things. So there are quite a number of things we can do. But in terms of initial resuscitation in these patients, definitely start with fluid boluses in them, assess for fluid tolerance because they want to overshoot, start vasopressors early enough and see if that might get you patient out of the woods. Of course, at the same time, look at the source of sepsis and intervene there as well. There's a question, Dr. Joyce. If I do not have an infusion pump, can we give vasopressors boluses? What's the rationale for administering vasopressors in a vessel proximal to the cubital fossa? Dr. Joyce?
So it would be difficult because the half-life of most of these vasopressors is about 2 minutes, and that's the reason why they are given via infusions. So if you don't have an infusion pump, you struggle, but I guess you can figure out something. Maybe you can use a burette. The thing is, you may give, if you're to use a burette, or just because I've seen in places where people will put them in IV fluids, you may end up giving more IV fluids than you'd want to give, which is a bit counterintuitive. But I guess we can come up with a recommendation for how to deal with places in which patients are in septic shock and people don't have infusion pumps. The next question was about the cubital fossa. So the thing with vasopressors is they are known to extravasate, and when they extravasate, they can cause ischemia. So initially, the recommendation was with all patients, especially depending on the concentrations, all patients who are on vasopressors, they should you should have central lines in place to avoid such complications. However, I think that the current recommendations, of course, they put a low resource settings in consideration. So, but then also there are some patients with whom you can give vasopressors and they may need central line. They may not need central lines because central lines come with other complications, including bloodstream infections and other complications. So it's better the cubital fossa has big veins and the less likelihood of ischemia necrosis in case there's extravasation. So that's when you're going to give a vasopressor, it's better to choose a cubital fossa vein that's big.
I guess in addition to the reason you're giving for choosing the cubital fossa as the site is that you also don't want a line that's going like to be disturbed by movement, so the flow is constant. Because that's common when you put a line in the wrist, on the wrist or something. When a patient flexes or something like that, the flow may be interfered with, and you may have trouble with that. And of course, remember also that the concentration of the vasopressor you might administer in a peripheral line may be lower, which risks putting a patient into fluid overload states in terms of the volume of fluid you're going to run to sustain hemodynamics. Just an addition there. So next question is there a role for other plasma expanders like hemocyalurosobilact in septic shock? And 2, in patients with septic shock and severe anemia, is blood transfusion part of the 30 mils per kg? Dr. Joyce?
So I don't know the active component of rhizobilact. I guess generally giving, I think colloids are generally not recommended as per these current guidelines. Generally, the use of colloids, because most of them are either starches or gelatins, there's usually no mortality benefit with using of colloids, and yet they have a bunch of side effects like anaphylaxis and cause of acute kidney injury. So from my endpoint and my understanding of these current recommendations, I would say no. Unfortunately, I think that's one thing that I missed out. Blood transfusion in septic shock. We need to keep the HB at least 10. So we'd need the transfusion transfusion of patients of anemic patients is recommended to improve perfusion. Is the in a severely, I think your question is in a severely, I don't know whether this is in a severely anemic patient whose HB is probably below 7. I don't know if that's the question, whether the blood is part of the 30 mils per kg. I don't think so, but I'll pass that question on to Dr. Erasmus. I don't think so.
Well, it depends on what you're doing. So if the question is, the patient comes in and they're anemic, the question are they hypovolemic at the same stage. You have to be careful. Now, patients anemic may have had the questions, anemia acute or is it chronic? It's acute. Sure, maybe there's not so much of hemodynamic disturbance in the direction of cardiomyopathy due to anemia. So in that case, you may say, okay, fine, I'm expanding this. Of course, you must know the reason for the anemia. Maybe the patient will be bleeding, it's a GI bleeding that's causing them to be anemic. In that case, volume expansion will definitely have to include the replacement of the lost blood as well. In the patients who are chronically anemic, all come in when they are in shock due to anemia. Now the concern there is that their heart may not be able to handle the volume in a short time. So you have to be very careful. Because I like to tip towards the cardiogenic part of shock instead. So maybe you want to first restore perfusion. Maybe you want to make sure you're using maybe inotropic something to support them, and then slowly transfuse to replace the HB. But yes, in some situations, blood may be used as part of the volume you're going to use for expansion. Yeah, in fact, you have to factor it into the fluids you're giving the patient. But how you're going to administer it matters. Are you going to give us a rapid bolus? Are you giving us a slow bolus? So in immediate resuscitation of a septic patient with the fluid, you usually want something that runs fast and naturally crystalloid. Blood may be used to correct anemia, and we don't really know the exact figure for every patient at which anemia becomes a major problem. A number of experiments have been attempted in animals, and there have been varying signs, or thresholds at which the patient gets unstable. Some start getting unstable at HB of maybe 7, some start getting HB of about 4. It depends. And in humans, there have not been so much of such experiments. So at the end of the day, when a patient is sick and septic, your first thing is to restore perfusion with the quickest means, and then you can correct some of those derailments later on. And I guess going back to the pathophysiology of septic shock, the aspect of the health of the glycocalyx, there is something called sphingosine phosphate, which kind of is responsible for the health of the glycocalyx. And it gets depleted in sepsis, and somehow its restoration comes in only 2 forms usually, in terms of blood, or in terms of red cells, or in terms of platelets. So technically, if you notice in patients who get septic, they kind of rapidly drop their HB, maybe from a production perspective, from a consumptive perspective, from a hemolytic perspective. And maybe that accelerates the dysfunction in the glycocalyx as well. And similarly, platelets getting consumed in the fight back against sepsis could maybe accelerate that, and transfusing those might help. Now, none of this so far justifies the use of blood products as plasma expanders in patients who are septic and hypovolemic, unless they're also bleeding actively. So what is the HB threshold? There's something called the TRIC trial. We're really just looking at extrapolations of transfusion of patients who are critically ill. just to determine which HB is appropriate. So for most patients who are septic, for most critical ill patients, an HB of 7 and above tends to be appropriate, and somehow that's a threshold they follow for both pediatric and adult patients. However, if a patient has got high risk of myocardial stress or brain injury, like patients who have got severe brain injury, or patients who have got myocardial instability from, say, cardiogenic shock, or they've got an MI, in those patients, you might want to reduce the myocardial demand by increasing the HB so that the oxygen carrying capacity is increased and therefore the delivery of oxygen is better. So the threshold for those patients tends to be slightly higher, around 8, 9, and some of the artificial figures that we choose to put in. But generally, we know that increase the HB more than 10 might increase the viscosity of blood, which might make the blood flow of root tissues more sluggish in sepsis and other critical states, and maybe increase the risk of things like DVT and stroke, and maybe just increase the myocardial work as well. So generally, we're looking at an HB in the range of 7 to 10 overall, but at the same time, the most important thing is to individualize the patient at all times. Yes, Anissa asks, sorry, and Anne asks, okay, sorry, Anne is giving a response to Anissa. She says you can time the rate by count the drops in a given set per hour. Not the best, but better than nothing. Absolutely. You need to remember that different giving sets have different calibrations. Not all giving sets will have the same number of drops for 1 cc. Some of them will give 15 drops as 1 cc. Some will give 20 drops per cc. So you have to look at the kind of giving set you have. Also remember that the rate will depend on the height of the drip of the bottle that you put above the patient. So if it's so close, the patient might slow very sluggishly, among other things. And more important, also remember the location of your IV so that the flow is better. So we have gone past time. We are 14 minutes past time. So I just want us to make some concluding remarks. Some questions will be answered as we go. If you meet the presenters anywhere, they should be able to address some of your questions. Allow me just to share with you a few take-home points from today's talk. So I will really talk about the key steps in care, just summarizing what the presenters have been presented to us. The first and very important part in the care of septic patient is screening the septic patients. It helps us to identify those who are at high risk of dying, and therefore you are able to direct them to the right place for care. So we're talking about taking to ICU, or if they're in the emergency department, escalating care quite quickly, putting in a number of concerted interventions to help the patients. So you want to confirm or suspect infection, and then apply screening tools in the ED or in the ward. QSOPA is a very quick one, just 3 parameters. The patient scores 2 or more of those, they are sick. They need to go to the ICU, they need to have your escalate care. If you have the resources, you can check lactate, but more importantly, lactate is more helpful as a trend, and that trend allows us to know that our interventions are working. Immediately institute resuscitation these patients. Remember, emergency airway breathing circulation is a disability. Do not ever forget glucose and further investigation. So primary survey is key in these patients. Assess the airway and breathing and support them. If they need to be intubated, you need to ventilate them in a protective way, because septic patients have got a multi-organ involvement, which also puts them at risk of ARDS, as Dr. Preach presented earlier on. And so the lungs are likely to have disturbed compliance, and the more aggressive your ventilation, the more you might worsen the lung physics and cause worsening injury to the lungs. Oxygen wars, what's the optimal oxygen level? You know, and we probably don't know the exact figure. If we could only monitor, I think the best is to monitor the impact of oxygen saturation, oxygen levels in the body to function in the patient. But overall, you probably don't want to be aiming for very high oxygen levels in these patients. anything that's adequate to keep your oxygen saturation at a level that allows your system to trigger intervention is key. So, you might say 92% of the patient in the ward. That way, you have time to call in the ICU team before the patient is in the 70s. Maybe if the patient in the ICU, you might accept anything around 8 and above. Other parameters, like if the patient is so anemic, you might have higher saturation. If a patient is, has got a higher HB, you might be okay, knowing that the delivery is okay, among other things. But those are things to think about. Fluid resuscitation is part and parcel of the hemodynamic resuscitation of these patients, and it's very key. You want to provide fluid boluses to restore perfusion from volume expansion. Of course, follow a targeted approach where you're aiming at restoring perfusion, not just to pour fluid in patients. It's not about the number, it's about the impact on the patient. Fluid responsive assessment, each time you want to give fluids to the patient. The choice of fluid, Dr. Joyce has ably taken us through the different types of fluids, particularly the ones that are probably not highly recommended. Colloids being very expensive, maybe having starches having a number of associations with the adverse events might be avoided. But of course, I prefer, I'm a disciple of individualized therapy. One patient might be harmed by something, another might be benefited by something else. Vasopressors and inotropes, starting them in tandem or in concert with the fluid kind of helps to reach fluid, resuscitation goals quicker, and also reduce the amount of fluid you might give the patient. But of course, remember that extraneous inotropes, especially catecholamines, are poisons to the body as well. So you have to mitigate the effect. There are new vasopressors on board in the market that if your patient can afford, it, be beautiful. Things like vasopressin is now in our market, much as has been in the developed world for so many years. We are such a shithole country. It takes so long to get things going here. Vitamin C, low. So monitor perfusion, monitor the impact. Could be by clinical staff, which is surely possible anywhere in this country. Source identification and source control is probably the most important part of sepsis control, sepsis treatment. So talking about head-to-toe assessment of patients on admission, but also every day in the ICU, do a head-to-toe assessment to determine the sites where infection might be. And remember that one site may be infected on day one on arrival, but maybe the next, after a few days, another site may show up. And that especially happens for patients who end up on supportive care. You've exposed their airway to infection, they're likely to get a VAP. You've exposed their bladder to infection, they might get a UTI, among other things. And then usually some patients have delayed sepsis, especially if they go into the immunosuppressive state. And so you have to think about some atypical germs in them as well. So source identification and control is key. That can be established by clinical examination, point of care, ultrasound is key. You can get a chest X-ray, brain imaging, get a lumbar puncture, sites, tracheal aspirate, sputum, stool. If there's an effusion, tap it and assess it. If it's a ascites, take it. The knee effusion or arthritis, take off that fluid to assessment. It helps to identify something quickly and work with your lab for quick turnaround time of the labs that you're sending out so that you can ideally start treatment properly. Source drainage, surgically or by interventional radiology is key. Of course, we use the landmark method for things like paracentesis. We can just examine the patient. Maybe if you have an X-ray, gives you an idea about the size of the effusion. You can actually put a needle there, just using landmarks. But if you have an ultrasound, even better. Antibiotics, the de-escalation therapy approach is key. Here, you want to start as broad and appropriate for the disease and the risk of a patient for resistant germs as possible. So patients who come from a community with no exposure to antibiotics, you might want to imagine that they have sensitive bugs. And as such, you might want to start with just common antibiotics, ceftriaxone, amoxiclav, quinolones, depending on the site and the likely bugs that you suspect for that kind of infection. But of course, if the patient has got risks of hospital-acquired infections, could be or healthcare-associated infections. That means there's a risk of resistant germs. Then you might want to go big. And then after cultures return and sensitivity profiles are shown, you may de-escalate appropriately. Follow clinical and biomarker monitoring to determine whether you are resolving disease so that you can shorten the time on antibiotics and the cost of care, among other things. General care for different systems is key to make sure the patient is treated holistically and not just as an infected patient. And definitely review, repeat, review, repeat. That is what we do to save patients who are sick. I see on the chat, Dr. Cornelius has been responding to some of your comments. And given the time we've spent here, we've gone overboard. I would like to draw this to a close. On the chat, there is a link shared of the landmark article that defines sepsis today, the Sepsis 3.0 definition. I'm posting it again. Kindly click on the link and read that article if you've never read it. If you've read it before and forgotten some of the aspects in it, please look at it again. Go and look up the surviving sepsis guidelines and improve the care of patients who are septic. Continue asking questions, continue reading around this, continue interacting with people who do this all the time. We are happy to help. Thank you very much for attending today's chat. I would like to bring this to an end. Thank you very much. I would like to see you next week on Friday when we shall be tackling the microbiological aspects of care of patients with sepsis.